Good morning or good afternoon, everyone. We're just going to wait about maybe another minute or so, and then we'll get started. This is Shiloh Jones from not from Families USA. Excuse me. All righty, I'm going to get started right at 1 p.m. since we have a really great panel of presenters this afternoon. Quickly to introduce myself, my name is Shiloh Jones, Senior Manager of Health Equity at Families USA, and wanted to welcome you to our next Health Equity webinar, Community Voices, How State Policymakers Can Advance Health Equity. This is a webinar featuring a report that our Health Equity Academies team completed earlier this year, and we'll get into a little bit more of that later. Next slide. So quickly for the agenda for this hour, I'm going to really quickly go over some housekeeping items, and after that, I'll turn things over to my colleague, Cheryl Fish-Parcham, who will give a background of the Academy report I just referenced, how we structured the report, some of the findings, and what we've learned. And most importantly, most excitingly, we'll be also hearing from a number of community leaders on their recommendations and lessons learned on some of the key focus areas of this report. I will first go over the logistics, and then I'll give really quick intros, and then I'll turn things over to Cheryl. Lastly, we'll have maybe about 10 to 15 minutes for Q&A before we close. Next slide. So I'm sure we're all fairly familiar with Zoom at this point, but just wanted to go over quickly how to use the chat box and to raise your hand. So you'll see here on the screen, if you want to put any comments or questions, etc., please use the chat box to send messages either to the hosts or the panelists or to all attendees. And you can choose who you're sending to with that drop-down menu. Also, you can raise your hand here if you want to ask a question verbally. Lastly, if you want to use the Q&A window to ask specific questions to the host or the panelists, we'll either reply back or we'll answer your question live. So before I get to the next slide, I'm going to quickly introduce our panelists and then turn things back over to Cheryl to kick off the content portion of this session. So first, we're happy to have Gabriela Barbosa, who's the Managing Director of Policy at the Children's Partnership, where she leads the development, implementation, and supervision of a multi-issue advocacy agenda focused on advancing systemic changes that protect and promote the health and well-being of children from historically marginalized communities. Gabriela has over a decade of experience using various advocacy strategies to achieve a more just and equitable society for children through laws, regulations, and executive actions that improve the conditions in which children live, learn, develop, and play. She previously served as the public policy director for a local elected official and a nonprofit advocacy organization, where she developed and utilized a policymaking approach that shifts power to community members as the driver of systemic change for themselves, their families, and their communities. We also will be hearing from Li-Chi Long, who is Northwest Health Law Advocates policy analyst and brings extensive experience in public health, higher education, international human rights, youth engagement, and reproductive justice in New York City and in Washington State. Li-Chi has worked for nonprofits at the local, state, and national levels, including directing the NYCLU's Teen Health Initiative and collaborating in the launch of 2 of Washington's accountable communities of health. She also is proud to volunteer as Mount Baker's Planned Parenthood's board treasurer. Lastly, we have Anjali Lafori, who is a mom, sister, comadre, psychologist, hypnotherapist, doula, and business owner. And I'm going to make sure I use the correct bio. As a former faculty developer and professor specializing in the psychology of gender and culture, her degrees are from Arizona State University and the University of Southern California, and in counseling psychology with an emphasis on multiculturalism. Since transitioning out of academia, Anjali is incorporating her varied experiences within the nonprofit sector. Given both her business and educational background, she is now focusing on her role as the co-executive director of operations and community relations for the Seopatli Collective, a nonprofit organization that supports urban Indigenous families to reconnect with ancestral knowledge. As a bilingual professional, Dr. Lafourie is a regular contributor to podcasts, called on for speaking engagements, and as a consultant providing leadership and counsel to a variety of boards and organizations. Thank you so much for the three of you for joining us this afternoon or morning. And with that, I'll turn to the next slide and turn things over to Cheryl.
Well, thanks a lot. It's been a joy to work with many people on a report, Community Voices Recommendations to State Policymakers for Advancing Health Equity. This is a report that was done by a team of us at Families USA, based on structured interviews with leaders from 50 state and community-based nonprofit organizations, and thanks to many of you who were part of that interview process. We also did a literature review for the last year and a half of priorities of health equity organizations. And in looking at both of those things, we asked, what are the top equity issues impacting communities of color in America? And what are possible solutions to address those issues within health policy? And our report is based on the findings of that. Next slide, please. So our report includes a number of quotes from community people, as well as bringing those into overall themes and recommendations. And here are a few of the quotes. People writing the policy are so far removed from the needs of those facing inequity. We've seen shortages of service providers across the Indian health and services and tribal and urban Indian health organizations. A lot of people who do healthcare work have anti-Blackness built into them. It's part of the culture. And you'll see the others there. I won't read them all to you, but just they were very compelling to us, and we are glad to be able to work with the community to think about solutions to some of these problems to lift up to policymakers. Next slide. So the themes that came out of the interviews as well as the literature are these 7, and we then have more detailed recommendations along each of these 7 themes. We'll only be able to lift a few of them out today, but please feel free to read the report, and we hope that it's useful to you in your conversations with policymakers. Next slide. So one of them, just to give you a flavor, was in mobilizing to fight racism and bias. One of the recommendations we heard was the need to be proactive in efforts to combat racial myths that undermine healthcare. And that comes up, in the need to do something to make workers be more aware of patients that they're serving and their needs, but also in the research. And a lot of clinical trials have not included people of color. And the National MS Society is an example of an organization that is working to do something about it. Until recently, people thought that multiple sclerosis didn't hit the Black community because there had not been any research about it. And so they're involved in this We Will Be Seen and Heard campaign now. And I just want to make everyone aware that Medicaid can now pay the cost of participation in clinical trials. So if you know people who might want to participate in a clinical trial, please work with your Medicaid agency to make sure that their transportation costs and other costs to participate are paid. Next slide, please. So now I'd like to turn it over to Gabriella to talk about another recommendation here, which was that states should fully integrate community health workers into their care teams. Next slide. And Gabriella.
Thank you so much. Really appreciate the opportunity to be here with you all. Again, my name is Gabriela Barbosa. I'm the Managing Director of Policy at the Children's Partnership. The Children's Partnership is a California-based children's advocacy organization dedicated to working to advance child health equity. And what is our vision of child health equity? This vision is a California where all children, regardless of their race, ethnicity, or place of birth, have the resources and opportunities that they need to grow up healthy and thrive. And our mission is to advance this vision of child health equity through research, policy, and community engagement, which brings me to why I'm here today. In the last year, I would actually say in the last 2 or 3 years, we've been exploring and publishing policy briefs about how the systems that serve children can be reformed, specifically to center the needs of children of color in order to improve the conditions where they live, learn, develop, and play. In these briefs, we consider opportunities to disrupt oppressive systems, defer to community leadership, and demand bold innovations that put the well-being of our children first. Next slide, please. So one of these reports, Community Health Workers Advancing Child Health Equity, is a culmination of listening sessions we hosted in 2020 in both English and Spanish with members of a community health workforce, which includes promotores, home visitors, CHWs, community doulas across our state, and our work with partners who are leading the way in advancing health equity for children. And the research that we did really highlights how a community health workforce is a key and integral component of addressing and eliminating health equities that impact children and youth. So this policy brief really served as the foundation of our statewide policy advocacy around this workforce and underscores the enormous value that community health workers and promotores have, specifically in supporting the health and well-being of children. And to give you a quick summary of what's included in our brief, I put here just 3 high-level key takeaways and recommendations that we've really been highlighting at the state level and advocating for. First is community health workers and promotores play a critical role in protecting and improving the health of children and provide various services and care that support their physical, mental health, and social emotional health. And we really are emphasizing and have been emphasizing this because community health workers historically in California have been historically used to serve adults with certain conditions. But through our research and our engagement with community health workers who serve children and families, we really see a huge opportunity to integrate this workforce into our state Medicaid program, specifically to provide preventive services to children and their families. Second, like I just said, like I just mentioned, we really view this workforce as really important, specifically to providing preventive services for children. And one key aspect of that is really the ability to include community-based organizations that have networks of promotores and networks of community health workers because they employ them, and the importance of having partnerships with community-based organizations who do already have this network of community health workers and promotores. And then the last recommendation I wanted to highlight from our brief is that all children and families enrolled in our state Medicaid program, Medi-Cal, should have access to a range of community health worker and promotores services across various social, emotional, physical, and mental health issues. And one of the key policy recommendations that we lifted up in this brief in order to implement or integrate a community health workforce into our state Medicaid program is through a preventive services state plan amendment at the federal level. Next slide, please. So now I'll just quickly go over 3 different statewide initiatives that we really view as successes in the space that do integrate community health workers to support the health and well-being of children and their families. First, this past year, our state Department of Healthcare Services came out with a comprehensive quality strategy that lists as one of its goals a 10-year vision for our state Medicaid program, Medi-Cal, that people served by Medi-Cal should have longer, healthier, and happier lives using a whole system person-cared and population health approach. And one of the initiatives included in that quality strategy plan is really the integration of a new benefit in our state Medicaid program. community health workers to provide culturally appropriate and community-based care. A second strategy that the California Department of Healthcare Services released that also includes community health workers is its strategy to support the health and opportunity for children and families. And this strategy, again, emphasizes the things that we have been lifting up in our advocacy around the brief, which is that this workforce is really integral, specifically to supporting the primary care and preventive needs that children have in Medi-Cal. And then finally, we're really excited that California has submitted a draft of a state plan amendment to create this new benefit in Medi-Cal that will be available for all children and families, where community health workers will now be able to provide preventive services as part of our state Medicaid program. And that was really necessary in order to implement the community health worker strategies that our state laid out in those two other initiatives that I mentioned, the comprehensive quality strategy and the strategy to support health and opportunity for children and families. In order to actually implement those strategies, we needed to submit a state plan amendment at the federal level to start being able to draw down federal Medicaid dollars to support those initiatives to ensure that all children enrolled in Medi-Cal would be able to access community health worker services. Next slide, please. So as I mentioned, our state submitted a state plan amendment to create a new benefit to include community health workers to provide preventive services for beneficiaries in Medi-Cal. And we had the great fortune of being part of the stakeholder work group that was providing guidance and advice to the California Department of Healthcare Services that was actually drafting this new policy and what it would look like. And we were really happy to see that the draft that was submitted to the Center for Medicaid Services, the federal agency that's now reviewing the policy, that it included a lot of the suggestions and recommendations that we had been lifting up over the last 3 years, specifically from our brief. And I'll just quickly mention those. So one, there in terms of who can actually receive services from community health workers under this new benefit, earlier versions of the draft had limited this new benefit to specific beneficiaries who either had certain qualifying conditions or who had documented barriers to their health. And we really were advocating for a broader definition, a definition that would allow all children to be able to access these services. So really happy to see that in the final draft that was submitted to the Center for Medicaid Services, that the Department of Healthcare Services ended up including a broad definition of who would be able to access these services provided by community health workers, broad enough to be inclusive of all children and their specifically the entitlements that they have under the EPSDT benefit, and specifically receiving preventive services like well child visits and blood screenings. Second, something that we're really excited to see included is that this new benefit includes community-based organizations as being able to supervise community health workers. So it's not just hospitals or health clinics or health plans that can supervise community health workers under this new benefit. Community-based organizations are also now able to supervise community health workers under this new benefit. And again, this was something that was really important to us. As I mentioned earlier, a lot of the models that we lifted up in our policy brief included community-based organizations that actually employed community health workers and promotores and were providing services to children and families. Third, the draft brief also included specifically child health and development as an area where community health workers would be able to provide services in. In the initial draft, child health and development was completely absent, and we were really excited to see the inclusion of that in the SPA that was submitted. Next, the services that are provided by community health workers under this new benefit don't have to take place in the clinical setting. They can also take place in community settings like schools and early learning centers, which we were also really excited about because we wanted to make sure that this benefit was available to children where they spend their most time, again, in schools and early learning spaces. And then finally, the draft SPA also includes a wide range of services that community health workers can provide specifically for children and their families under this new benefit. This includes helping children and families access the healthcare system, connect to community resources that address things like social determinants of health, food insecurity, housing insecurity, working with a child's primary care team to create care plans for the child, conducting screenings of the children, specifically developmental screenings, helping children and families enroll in government programs, and finally, providing individual support and advocacy. And that's it. All of those words were actually words that were included in the actual SPA, in the actual draft of the SPA. And again, we were really excited to see that it has such a wide range of services that we really feel will really benefit all children and families enrolled in Medi-Cal. Next slide, please. But we still see a need to continue to advocate around this workforce in the state of California. All those things that we were able to accomplish that I just mentioned through the state plan amendment, none of that required legislation. All of that was done through administrative advocacy with our state Department of Healthcare Services. And even though we were really excited about, or we are really excited about what's included in the draft SPA, we're still reviewing it to see if there's any need for continued advocacy. And one area where there's potentially need for continued advocacy is around the way that community health workers are reimbursed under this new benefit. That's still very much a discussion point with the stakeholder work group. And so the next sort of opportunity to advocate in our state around this workforce is through the creation of what our state refers to as a provider manual. And so this is sort of the way, after we get confirmation from the Center for Medicaid Services, the way that we will implement the new benefit, that will all be described in the provider manual. We also right now are advocating for specifically money through our state budget to provide training and recruitment for community health workers under this new benefit, specifically around child health and development. Last January 2022, we're really excited to see our Governor Newsom, propose a $350 million investment to recruit and train community health workers. But unfortunately, child health and development wasn't included as a specific area. So we're still very much working around that. And then finally, based on what we see is implemented with this SPA, there is a potential for future advocacy around state legislation, potentially next year, that really focuses on developing this new benefit for children and ensuring that community health workers are integrated into a child's primary care team. That's it for me. Thank you all.
I'm wondering if we can just get, I can ask this really quick question in the Q&A to you, Gabriella, before we go forward. Someone asked, does California use Medicaid managed care? If so, does this work differently?
California is using managed care and it will not work differently. So this new benefit will be available to both beneficiaries who are enrolled through managed care and also fee for service.
Great, thanks, Gabriella. Luci, I will turn things over to you.
So if we want to go to the next slide. I really appreciate being included in this fabulous panel today. We are really excited to share our victory with you. For over 2 decades, Northwest Health Law Advocates has worked to improve access to healthcare for all Washington residents and to advance healthcare as a human right. So our focus has been law and policy, and we're just really excited that we've made progress this year in significant ways. So Washington had already expanded Medicaid for adults and extended after pregnancy care for 12 months. That happened in last year's session. But the Health Equity for Immigrants campaign is yet another expansion towards more access for everyone.
Excuse me for just a second, Luci. Are you able to turn up your mic a little bit? We're having trouble hearing you.
Sure, I can. Can you hear me better now?
Not quite yet.
Okay, so I can try to project. Does that work?
Okay, thank you.
All right. So the Health Equity for Immigrants campaign is a multi-year campaign. We've been working for the past several years with community leaders, with providers, and with other advocates to really tie together a broad coalition of partners to expand healthcare coverage to people regardless of immigration status. So it was really important to us that this be a community-rooted and community-informed approach. So given the disparities from COVID, it was very clear that immigration status provided a huge barrier in Washington state to equitable and accessible health coverage. So as part of the coalition, we worked with the Asian Counseling and Referral Service. We worked with the Washington Immigrant Solidarity Network, as well as sort of more traditional legal partners in advancing this goal. So if we want to go to the next slide.
And Licha, could you just try one more time to see if there's another way to turn up your volume a little bit?
My volume is at 100%, so I can try to talk louder.
Thank you.
Hear me?
It's still soft, but we can hear you.
Okay. Usually folks don't have a problem hearing me, but I'll try to project. So last year, our legislative champion introduced a bill that didn't make it out of committee. But this year, despite being in a short session of only 60 days, we had significant wins. We pursued a budget strategy, and this year that meant that our Medicaid agency, the Healthcare Authority, was directed to start work on a Medicaid equivalent that should be available to all Washingtonians, regardless of immigration status, starting in 2024. That is on par with other folks in Washington. So that goes up to 138% of the federal poverty level, and is meaningful access with $0 cost shares, no premiums, no copays. In addition to that, the state budget directs the Health Benefits Exchange, which administers our state exchange. It's called Health Plan Finder. To apply for what's called a 1332 waiver. And that basically is a mechanism to address part of the ACA to let states have the flexibility necessary to serve our residents best. And so if the 1332 waiver is approved, that would mean that anyone, regardless of immigration status, would be able to purchase health insurance, a qualified health plan, through Health Plan Finder. In addition to that, the legislature earmarked subsidies for people up to 250% of the federal poverty level, again, regardless of immigration status. So we're super excited to see those included in the budget that was signed by our governor, and are eagerly awaiting the next steps. As folks on the call are probably all too familiar, legislative wins are great, but implementation can take a while. So if we want to go to the next slide, this is the timeline we're looking at. So currently, the Health Benefits Exchange plans to submit this month their 1332 waiver request that would be reviewed by both CMS and Treasury. The waiver will also be reviewed by OMB and the White House, but we are eagerly anticipating and requesting an expedited review process. So hoping to hear back by August 1st. Not sure if that'll happen, but that's the request. The feds actually can take 45 days just to say whether or not the application is complete. And once they do that, they have up to 180 days to review the entirety of that application. Sometime during that 6-month period, there will be a 30-day public comment period. So during that time, we're really hoping that all of you, national organizations and other advocates will support this effort. So we were really heartened working with our 100+ partners in the Health Equity for Immigrants campaign that we managed to get 95 organizations signed on to a letter of support that will be part of the Health Benefits Exchange application, 1332 application. We also activated our activist base and got people to send individual emails to support this. Quite an undertaking given the complexity of the minutia of waivers at CMS. But we are keeping our fingers crossed and looking forward to that federal decision, because if they say yes, then the Health Benefits Exchange will work on implementation. In addition to that, there will likely be some need for legislative action in our next session, which runs from January through May of 2023. You know, we really want to make sure this program is adequately funded. We want to make sure that, you know, appropriate guardrails are in place. And all that is to sort of get things queued up for November 2023, when we anticipate open enrollment will start, so that people could actually sign up for coverage starting in January 2024. This has been, as I said, a multi-year effort that's taken many people, many advocates, and will go a significant way in removing barriers to allowing all Washingtonians, regardless of immigration status, access to essential health care. So we also anticipate about $1.71 million in federal cost savings. And so meeting that guardrail for the 1332 waiver, also anticipating a reduction in premiums for everyone who participates in the exchange. So we see this as a win-win across the board. Additional people covered, additional people with health insurance access, and meeting those federal guardrails. So hoping we have your support when that public comment period opens sometime this summer.
Can we go to the next slide? Before I turn things over to Anjali, I'm just going to ask another couple of questions that were in the chat. Someone asked, is there also work to deal with racism, et cetera, when people go for health services with or without coverage?
Yes, there, I think, are lots of complexities in accessing healthcare, and in terms of the broader conversation around culturally appropriate services and cultural competence. Washington State has created a statewide Office of Equity, and also appointed and designated folks in each agency. So, you know, we work with the Healthcare Authority, we work with the Health Benefits Exchange. There's a health equity technical advisory work group at the Health Benefits Exchange that we've worked with for years, often around language access issues. For example, you know, we at the Northwest Health Law Advocates really fought for incorporating ACA civil rights protections, which are, I think, Section 1557, into state law, and to make sure those include language access rights. Of course, again, that's only part of the solution, because while rules may be on the books, enforcement is often a challenge. And you know, there are challenges that remain in terms of access to interpreters, especially among smaller populations. For those of you who may have seen some of the national stories, Spokane, which is on the eastern side of the state, has a very small population of Pacific Islanders that endured really grotesquely disproportionate rates of COVID, hospitalization due to COVID, and COVID deaths. They're also very overrepresented in the numbers of people who have trouble accessing interpreters and translators when seeking healthcare. That's partially a small numbers issue. That's partially just the history of colonization in the United States. So that is definitely part of the challenge in implementing any new benefits, and when we are in dialogue with community and with the agency to address in ways like culturally competent outreach, as well as addressing those structural issues and ensuring that there are interpreters and translators, in addition to the sort of those structural issues, in addition to the just making sure you have trusted resources sending those messages and letting people know that this benefit exists.
Thanks, Litri. And I think we'll have time during Q&A if any of the attendees or others want to either ask more questions or even share what they have going on in their states. I think your last answer was a really great segue to our last presenter, Anjali, who's going to be speaking about the theme of providing culturally competent behavioral health care. So Anjali, on to you.
Good morning, good afternoon, and I'm going to apologize in advance that my lovely dog is near me and snoring. So if you hear that, it's an animal and not this big burly person. See, there it is. I hope y'all can't hear that. But anyway, my name is Anjali Lafari, and as was shared, I am the co-executive director and co-founder for the Siwa Patli Collective. Siwa Patli means women's medicine. It is a word in Nawat. And the way that the collective began is we responded to a call. That's most of our work. We feel that we respond to either the calls of individuals or the calls of our community. We like to say that our work supports urban Indigenous families from womb to tomb, and we do that in one of four ways. One is through cultural revitalization and education. The second way is through food justice and land restoration. I'm sorry, I'm laughing at my dog. The third, I hope y'all can hear that. The third is through birth equity and reproductive justice. And the last way is through advocacy and consultation. Oh, mamas. Okay, anyway, if you hear me say mamas or mouth mamas, I'm not calling my mom, I'm calling my dog. Okay, let me keep going. Show us the dog. No, you know what? I have the background on, so it won't show up, and I just moved, so you would see also a lot of boxes right now. So she's knocked out, and I'm trying, I don't want to throw things at her to wake her up, but anyway. All right, let's keep rolling. Let's keep rolling. Okay, so I feel like people never know what they're going to get when I come on and present. This is a good example. Okay, so what am I talking about? The collective. Yes, so in our work. The other part, really quickly, I also want to kind of ground myself where we're physically located. So we're generally in Phoenix, which is Akamel, Atham, and Pipash territory. And I just want to ground where I'm from, and bring in my parents as well. So my mom is Maya from Guatemala. My father was Afro-Cubano, and so Taino and Arawak. Next slide, please. So for the sake of this presentation and the many things that the collective does, we wanted to talk about culturally centered responsive care. And one of the ways that we did that and are doing that is through our Dignified Full Spectrum Birth Support Fund, which is called the Collective Birth Fund for short. This came out of a response to the closure of the Phoenix Indian Medical Center's labor and delivery unit. That facility serves about 300 tribes where people obviously travel to get their services through essentially an Indian health services. When that center closed, we immediately were asked to try to mobilize and create a response, and it coincided with receiving grant funding. So what we did is we started to create this fund for folks to apply so that they could have the culturally centered birth that they wanted. The response from the state and also the response from the hospital was to kind of send them to local hospitals, but again, where there was no guarantee and or conversation, on top of also little to no announcement of the hospital being closed. So folks were literally walking up to the labor delivery unit with a sign on the door stating that they weren't able to be attended. Anyway, so we started this fund so that folks could have the birth that they wanted, and they could seek outside services if what they were being offered didn't fit their needs, or so that they could supplement whatever culturally centered or culturally responsive care they hoped for. Also, I think another part that's important with the change, some of the legislative changes as it relates to Roe v. Wade, and also really some of the work we've done, I think it's important to share that the collective supports reproduction through all phases, right? So there's, for this particular conversation and fun, there's a lot of emphasis on babies coming earthside. But we want, all phases of reproduction need to be healthy. And some of our birth workers work in spaces where termination, is a part of some of that reproductive healthy response. And so this fund is also we anticipate that it will need to expand to support more phases of reproduction. Let me have you, I want to have the next slide be played, please. And this illustrates, I'm going to set this up. Somebody who was supported through the Collective Birth Fund. And I think it really illustrates how culturally responsive care is centered and how some of our work throughout the collective.
Hello, my name is Lisette Zamudio. My partner Lisette and I want to thank both the Groundswell Foundation and Siwapakli Collective for their financial and loving support. Through midwifery care, we have been able to find various resources such as ultrasound, where I was able to hear our baby's heartbeat for the first time. The best part about it was being able to bring my partner along and experience the whole pregnancy together. The midwife we worked with has helped me find natural ways of healing. With the Arizona heat coming in, I've gotten headaches, but she was able to recommend natural remedies to relieve the pain and advice on staying hydrated. It's important to us that we prioritize natural healing because we believe that's the best for our baby. We are so thankful for our midwife and her care for us. She makes sure that we own the process and makes us feel safe as well as confident. Once again, we thank you all so much.
Thank you. And we can stay on this slide for now. In addition to the Collective Birth Fund and our individual response, the collective was also called upon with other partnering organizations to help to craft what essentially, was like the early momnibus bills that were trying to get doulas to receive support through Medicaid or reimbursement through Medicaid for doulas to be activated within birthing spaces. We were initially called on to provide consultation, right, about our community and Indigenous communities and how they would be best served. That has gone through a very complicated process. The bill did pass, like many, and it's a copy of the Oregon bill and some other states where doulas are now being paid, $75 for the birth. You can imagine that that's not what we advocated for. Our key points of advocacy were one of related to recognition of a traditional doulas, traditional midwives, so recognition of their knowledge set, as opposed to only recognizing through maybe one or two nationally certified licensing boards for who qualifies to be a doula or a midwife. And then the other part of this creation of advisory councils to be able to determine an equivalency for how traditional or ancestral doulas or midwives, how their work is able to be certified and recognized under state care. I think the biggest difficulty, I don't have successes out of this, short of, I think the success is what are the program that the collective has created, but state successes, that has not happened. So we were essentially, once we challenged our state legislator, you know, in a place of advocacy, in a place of accountability, in a place of them kind of their racist practices, then we were shut out of the process. So, you know, I think the biggest thing I would say is if you ask a community agency for their recommendations, reimburse them for their time, kind of listen to what they say, and then recognize that that accountability is reciprocal. And that once you open the door and you want our advice, then we're also going to kind of have comments about the way that you operate in your space and the ways that you hold yourself as a public individual. And then the most important thing is recognition for different types of knowledge. All right, next slide. And I'm wrapping up. So I just want to thank you all for your time, right, in all of our ways and all of our languages from all of the directions. And I'm open to any questions or comments.
Thank you, Anjali. And I also will take a pause here. If anyone wants to unmute and ask their question verbally, please feel free to do so. We've also been keeping an eye on the chat and in the Q&A box, but I'll pause here to see if any of the folks in the audience want to ask any of our panelists, including Anjali, any follow-up questions. Laura, go ahead. If you can keep them in the chat and I can read them out, or feel free to unmute. Oh, or I guess we can put them in the Q&A box if unmuting isn't working. Anjali, I think you're right. I think ignore what I said about unmuting, but please feel free to use the Q&A box so we can just see the questions instead of the other comments in the chat. Well, Anjali, I do have, I guess, one follow-up question. I know you said that you don't necessarily have successes as of yet. Going forward, like, I guess, give us, I guess, a forecast of the coming year, or your near to midterm forecast in terms of your advocacy in this space. What do you see coming forward for the rest of 2022 and beyond?
Sure. Actually, you know, I'll say when I said that, I meant from a policy perspective, right, or from a legislative perspective. We haven't seen that yet. I will say that something that made a big difference for us last year is that several of us sit on different task force through the maternal and mental health task force here for the state, and that's through Arizona Department of Health Services. That actually, and having literally just one person, you know, advocating for many Black and Indigenous groups here in the state has made all the difference in training dollars being funneled to our communities. So that has been a success. I've seen less money this year, and I'm certainly not putting that on any one individual. I do believe that because of the pandemic, funding cycles have been different. And then I think also because so many of us had to respond in particular emergency-based ways at all levels during the pandemic year, to then be able to kind of predict how the next year is going to be. As an organizationally, we feel that way, you know, of like, oh, what's our calendar like this year? Or what's our programming like this year? And so everyone's having to readjust, right? And so I believe that that's a part of what's going on. We will continue to kind of hold some of those spaces through the state task force. I think also for the collective, being seen as maybe a cultural authority and being asked to partner in some projects those are some of the successes. Let me be specific. One related to even our food justice work, being a part of city and state, the crafting of city and state grants to make them accessible to more organizations. Being called upon, I can jump to kind of the Roe v. Wade example, being called upon by the vice mayors and the city mayors to, what our stance is, to inform some of the responses, that are having to come out. Those have been some of the highlights. I think being able to assert ourselves as having some level of authority, not because we want to feel good, but because then that means that we can advocate for our communities.
Thanks, Anjali. Lychee, there's a couple questions for you here as well in the Q&A box. I'm gonna kind of go in order. I'm gonna try and bunch them. First of which is, if this 1332 request goes through, will Washington be the first state to offer undocumented subsidies on the state exchange? And then similarly, if your timeline mentioned a plan B if a waiver isn't approved, and what would that be?
The easier one. So yes, let me make sure my volume is all the way up. Yes, this will be the first 1332 waiver to allow folks, regardless of immigration status, access to not only subsidies on the state exchange, but access to the state exchange at all, or any state exchange. So in terms of Plan Bs, that is a more complicated question, and I think that is an ongoing conversation with our legislative champions, and what may be possible, especially if we're using state-only funds, and also what's possible given the complexities of IT and that build. Obviously, we really hope the 1332 waiver is approved, because that would offer parity. People would be able to use the same system.
To follow up, people asked about the actuarial analysis and how did that work? And I assume we can send out the link. Is there anything you want to say about how they think that it is going to work?
Sure. So, using very conservative estimates, the waiver application anticipates that in the first year, there would be 2,600 additional people who would seek coverage through the exchange. Now, the 1332 waiver is assuming current state. So we're not looking at the Medicaid equivalent. We're just looking at people who would purchase qualified health plans. But that 2,600 additional individuals who could purchase health insurance is calculated to bring in 1.7 million in federal savings. So that does meet that federal deficit guardrail. And by doing so, by increasing the number of people who are purchasing qualified health and dental plans, the actuaries anticipate a 1.4% reduction in premiums for everyone in the state. So that's where the win-win comes in.
Another follow-up for you, Lychee. Does Washington have a state health insurance assessment to fund state subsidies?
I'm not actually sure, but what we do have is legalized marijuana and an associated tax. And so the revenues from half of the revenues of those taxes are earmarked for funds to provide healthcare access for folks at lower incomes. So the upside of legalization is multiple, or there are many upsides to legalization, but one of them is the tax revenue that brings in, and the programs that can be subsidized or can be provided thanks to those revenues.
Really interesting. Any other questions? Please put them in the Q&As just to make sure that we don't lose them in the conversation in the chat. Just as a reminder, this webinar recording and the resources and materials I'll go quickly over in a few minutes will all be available on the website, and I believe we'll also be sending them out as well. So we'll also try and capture some of the links that have been shared in the chat as well. Thank you all for sharing. I've been trying to keep an eye on the presentation and keep an eye on the chat. So thank you all as well. So hearing no additional questions, let's go ahead and go to the next slide. As I mentioned, our presenters sent us a few additional resources about their work. We also have a few Families USA links here as well. This will all be available both on the Families USA website and in our follow-up email. So links to issue briefs, links to legislative recaps, etc., all related to some of the key topics we covered during this hour. Next slide. Also, of course, we couldn't end this webinar without plugging the next Health Equity Academy, which is going to take place on June 28th and 29th of this year. Applications are now open and will be closing on Thursday, June 2nd. The two focus areas or tracks, if you will, are going to be broadly health workforce and diversifying the health workforce, as well as expanding access to culturally competent behavioral health care. Obviously, these two themes are very much intertwined, so the overall format of the academy might be less tracks and more so a one large cohort, but we welcome your applications. Please feel free to share widely. I'm really excited to get the next group of advocates into the workshop and into our networks. And please feel free to email myself or Lauren Rosenbaum, who is our project lead with respect to the Health Equity Academy, with any questions, concerns, etc. So wanted to plug that as well. June 2nd, apply before then. And then I think we have one more slide. Last, we do have our next webinar in this health equity series. It's going to be taking place on Tuesday, May 24th, in honor of AAPI Heritage Month. We have a panel that we've planned, and we have a really great assortment of presenters for that webinar as well. Registration link is both on the website, and again, we'll send these links out to you all after this webinar. And actually, I think that might have been the last slide. So let me double check. And it is. So lastly, again, wanted to thank our three presenters, Lichi, Angele, and Gabriella, as well as Cheryl, for providing some of the context for the Academy report. Thank you all for joining, whether it's this morning or afternoon, and thank you for all of the work that you do in helping to advance equity and being an advocate for the communities that you are a part of. So thank you again for your time, and have a great rest of your day. Bye, everyone.